Hello, everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at RX Review. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Please join us after the webinar to have your mind blown by Silicon Valley's favorite magician, Dan Chan. And with that, I will send it over to our moderator who joins us from RX Review, Christy Callahan.
Hi, everyone. Thanks for being with us today. Let me just get the slides up and running. Does that look good to everybody? Are you seeing the right view? Awesome.
Looks great.
Great. Well, thanks for being here. We're really excited for the discussion and really excited for the opportunity to talk about how we can bring better information to providers, to patients, and how we can really help to improve healthcare affordability, access, and outcomes. So I'm going to jump right in, introduce our panel, and start to tee up the discussion that we're going to have today. I'll start with Sarah. Sarah is the Chief of Digital and Growth Strategy for Providence. She's leading their digital strategy and roadmap for execution, thinking about digital partnerships and business development, and also looking at technology evaluation and piloting. And, I think the important thing with Sarah is she's really a thought leader for Providence around how solutions can reach patients in a meaningful way. Sam is the VP of Interoperability at Cerner. He's focused his career on making healthcare more affordable, accessible, and coordinated. So the perfect person for this session. He's leading efforts to improve data flows and the user experience through Cerner's clinical and technological innovations. And Jim is here with us from CVS. He's the VP of Clinical Informatics and Interoperability at CVS Health. He's responsible for the clinical system strategy, provider workflows, and interoperability of clinical data. And he also focuses on building industry partnerships to support patient health. So with that, we'll go ahead and tee up what we're looking to talk about today. So we're going to start with just kind of an evaluation of where we are. On one side, we primarily have provider and payer information about a patient's insurance coverage, about the cost of procedures, the cost of drugs. And on the other side, we have providers and patients that are really trying to follow through on care plans, that are trying to access those services. And so, we want to start with, where are we? How are we doing in terms of connecting those folks? Talk a little bit about how technology is evolving and unlocking new opportunity. And then at the end, focus on what is that near-term future that we all kind of envision, and maybe two things. How near-term is it? How fast can we get there? And what can it do in terms of improving healthcare and healthcare costs? So just before we jump into the discussion, I want to tell a quick story. It's a drug-related story, but ARGS Review was kind of founded by Dr. Kevin O'Brien, and he had this interaction with his mother around her drugs, where she was paying a ton of money every month for a set of drugs that she needed to manage her conditions, to manage the chronic diseases that she had in her life. And being a provider, he was able to go through that drug list, compare it to her insurance, and reduce that burden for her by about $200 a month. And I think, as we talk about solutions, we see these opportunities everywhere, right? Plans have $0 drug lists. There are opportunities for patients really to kind of maximize their insurance benefit and maximize the programs out there in the market. But it's not always getting to the patient, and it's not driving the outcomes that we want to see. And so that's why we, ARGS Review, are here. Lucy is our guiding light in terms of who we're trying to help and how we're trying to make healthcare work better for patients. All right, so with that, panel, get ready. We're going to start with a little bit of a round robin. And Sarah, I'm going to pick on you first, but kind of two questions. One is, who is your Lucy? How do you articulate what we're trying to accomplish here? And what do you see as kind of the immediate hurdles that we need to work through in order to get better real-time data exchange up and running?
So our Lucy is two people or two players here. Um, the uh, the patient or the consumer that is the end user of a lot of, at least from a digital innovation perspective, a lot of the platforms that our team builds. And it can be anybody. It could be mom who is the head of household. It can be any user of really our digital properties. So that's one, and our digital properties as well as our services, of course, that goes without saying, our kind of core services. So our Lucy is that person as well as our providers. So and this is probably the least technical and most high level answer that you're going to get from us within this panel, but we can't do anything for our Lucy at the expense of our providers, and so we build and we partner for either of those two kind of constituents, and we do so, I would say, like, sort of, if we think about what's the importance of data sharing for those individuals, one, it's around ensuring that for the Lucys in this equation, it's personalized, it's relevant to them, it actually helps them make decisions in a guided fashion as opposed to just out there on their own, left to their own devices to navigate a really complex system. And then for our providers, our clinicians, it's about taking the stuff off their plate that doesn't require their judgment or decision making, and then providing them and just automating it. And you can't do that without data. And then finally, it's about supporting them at that point of decision with the other ancillary information that they need to make that decision. So those are kind of like, that's from an importance and who we're doing this for, that's how I would sum it up. There are so many challenges, but I think one of them that I'll just highlight from the provider perspective is the availability of that data and the way that it comes together within the context of not just at the point of care, but like prior to the point of care, at the point of decision making, and kind of built into the overall workflow, as opposed to in sort of either fragmented or overwhelming or other sort of non-useful ways.
Yep. That makes great sense. Sam, that's probably a good segue into you. Same question. Sure. Who's your Lucy? How are you thinking about the importance and what are the big hurdles?
Yeah, so I mean, fortunately, Cerner having such a significant user base in terms of providers and patients with their information stored at those providers, I feel like, unfortunately, Lucy is a person without a name or a history in a lot of times when they show up in our venues. And we actually need to get to a place where when Lucy comes in, it's a different experience than when Michael comes in, and it's a different experience when Joanne comes in. And the fact that we've all been through this, right? We show up in an emergency room or come to a new specialist dealing with some chronic issue, and the first thing they ask us is, well, okay, what's your name? What's your address? Not even demographic information about us. And when we all have unique medical histories, not to mention the social factors that impact our ability to adhere to medical guidelines, it's just wasteful and actually potentially dangerous if it's, not to mention a poor patient experience, if we ignore all of these aspects of documented medical history that are out there. Now, that's to say that's one part of it, but the fact is there is a lot of information that is securely exchanged on patients through the likes of Commonwealth and Care Quality and third-party partners, and where there's consent and where there's networks, we have a significant amount of data. And that speaks to maybe Sarah's point that with this enormous amount of data, in some cases it doesn't actually get to the end user in a way that's helpful or provides the insights they need to make clinical decisions. And if anything, sometimes it seems like a liability to access that information. So we have data consistency problems, and but the reality is, like, the end user workflow is where we really need to land as an industry from kind of maybe the pipeline we've been doing for a decade or more. And I'm sure we'll be talking more about this throughout the panel. So that's just kind of my introductory remarks. But this is a great conversation, and I'm sure we'll uncover more.
Awesome. Thanks, Sam. And Jim, how about you? Who's your Lucy? How do you articulate importance, and what are the big hurdles?
I think my colleagues Sarah and Sam both said it very well, but one of the things that strikes me is we talk about getting more information and giving a better consumer service and being essentially more engaged with our patients. Or if you think about when our patients come to us, they're coming to us as part of their day. So this afternoon I have a doctor's appointment, but we're waiting until, in many cases, until they arrive to really engage with them. And I think, and I think my colleagues would agree, it's like we need to be engaging earlier and more often. Now that means through different channels, but that requires different data. And as Sam rightfully mentioned, securely with consent, so everyone knows what data is available for them. But we have, and I sit in a unique place of in a world of payers and providers, and different types of payers even, and different types of providers. But it's universal across all of those. We want to make sure that we can engage with these patients and our members to make healthcare more accessible. And a big part of doing that is ensuring we have the right data at the right time with the right provider, taking some things off the physician to a nurse practitioner, or from a nurse practitioner to a nurse, another level of providers, because that's the way we universally will increase efficiency. That's how we get to everyone at the peak of their license with effective data availability.
Absolutely. Awesome. Well, let's move forward here. You all mentioned kind of the providers as well as the patients. So let's start with the providers. Obviously the provider is clinical to that patient decision making, right? They are really the person that can inform, can I switch drugs? Can I take it? Can I use a different procedure? Can I go get that procedure somewhere else, right? And so as much as we think about that provider experience as being incredibly critical to the patient decision-making, we also often get the question of, do providers really want more information? Can they absorb more information? How do we bring this forward in a meaningful way? And so what you see on the page is a survey, and I think it highlights two things that almost all of you mentioned, which is one, the information today is spotty, it's inconsistent, it's not optimized. But two, that providers do want to have this opportunity to support patients around cost, to avoid things like prior authorizations, and to have a more streamlined process of going from care planning to execution of those services, execution on those meds. And so, Sam, I'm going to start with you, but from a Cerner perspective, how do you think about that? How do you think about the workflows? How do you think about how you're engaging providers, and kind of where to focus and where to go next?
Sure. I think about it kind of as a funnel, right? So at the very top of the funnel, there's kind of three layers. The first one is just, we think about the complete network, right? If not all PBMs are participating, that's going to leave gaps for the diversity of patients that our providers see. If not all payers are participating in whatever capability we're talking about, that creates an incomplete network and gaps and workarounds. And so just at the network level, making sure that we have the right partnerships, consortia, regulatory frameworks to bring the broad network in. But then you get to the level of kind of complete and trusted data, right? Do we have, from those sources who are all participating, do we have improvements in data quality in and out of systems? And we spend a lot of time advocating for the adoption and improvement and consistency of things like FHIR, NCPDP, we were in the direct CDA, like all the standards we use to exchange information really need to be, more and more consistent and really drive quality at the point of consumption. And then, finally we get to the workflow, right? Because the workflow ends up being a real turnoff if either of those other two are not good. the network or the trust. But then, is it seamlessly available and available for the clinical user or the patient to consume in their natural workflows? And I would say these are non-trivial challenges at all of these levels, and we have to kind of address them all collectively. But given the amount of work we've done, probably more on the standards and network side, the majority of focus of my product teams today is on building trust, working through the workflow challenges and making it more consumable at the right points of care for the end user.
Right. And Jim, from your perspective, what information matters? To your point, you've kind of got a broad view here in terms of payer PBM side and provider side, and what information are you most focused on in terms of getting in the hands of those that are providing care?
Well, I think the most impactful is around the pricing information. Even though in this survey they don't discuss medication prices with patients, partly because I think we have not done a good enough job of simplifying the presentation and getting it to something that not only the provider can look at and quickly assess, but also for the patient. We don't need the provider trying to translate for us. We need to give them the information in a consistent and simple way. This medication will cost you this much per day or something like that, rather than some of the other pricing information that's in there. And I think that sort of change, that sort of simplification in the workflow that Sam had mentioned, his team works on the workflows, is going to lead to a drop in that number that don't discuss the prices, and again really enter into a better relationship or more holistic relationship with their patients. The information reliability has to be addressed as well, and I would love to dig into that number a lot more. But I think if you can simplify the presentation and encourage the discussions, part of the reliability I think is fixed in that simplification as well, because it might be is the data not reliable, or is the data just hard to understand the way it's presented today? So I think that's a crucial part of getting in there, and that will flow down, I think, to prior authorizations and other transactions as well.
Yeah, absolutely. And then Sarah, how do you think about this and the interplay between provider and patient? And to Jim's point, that kind of second to last bullet here around the discussion with patients, how are you guys thinking about that?
She's on mute.
I can give a couple of specific examples, actually, of how we're thinking about it and addressing it. But I want to, before I give those specific examples, I just wanted to give kind of two principles that we're kind of trying to adhere by. And I heard it, I heard Sam and Jim both reference it as well. The first is sort of this notion that we're not just working at the infrastructure level. Sam talked about it, like we've been laying pipes for a really long time, and that's not where we're really at anymore. We need to start moving kind of maybe up the hierarchy of need, or whatever you want to describe it as, and moving into workflow that matters and is actionable. And then on that note, the second thing I wanted to highlight is we're thinking about things much more, not like in traditional sorts of frameworks around like putting a big dashboard of information in front of a provider, but rather thinking about it almost like you're managing by exception, or by like actual specific sets of rules that are, again, actionable, as opposed to sort of blanket approaches to building something that isn't really functional in the workflow. So one example of that is actually the work that we've done with you all within RX Review. Is we've implemented it across our entire network, and any provider that's in Epic right now, either within sort of Epic, it's sort of transparent in the background. They can have either a button or a pop-up for them as they're going to be, sort of evaluating the options and pricing for their patients, for their medications. And they could do it if they want. They can go into the button and press it and look at it, or they can alternatively get a pop-up, but only in the cases where there is a therapeutic alternative that has some sort of meaningful value to the end user, to the consumer or patient, in terms of their prices. And so so it's not like that pop-up comes up all the time, or it's it's sort of like a forced workflow all the time. It's only there in specific instances, and so it's been really meaningful. And then building on top of that, for instance, as we've talked about, and I think Jim referenced, you can, once you get some of that stuff right, you can start to build in things like prior authorization, which is extremely painful for us as a system, but we're not quite there yet, especially like in terms of our specialty pharmacy business, but we're kind of heading in that direction as we've laid the groundwork for inpatient pharmacy and some other pharmacy stuff. So that's one example.
Awesome. So then let's move on and just talk a little bit about the regulatory environment. And, I think this also helps us transition from provider to patient, because we're seeing the regulations start to transition to patient in terms of some of the cost transparency rules, as well as, specifically real-time benefits expanding to enrollee facing tools. And so, question for you guys, and I'm going to go around the horn here. Jim, I'll start with you on this one, but how are you thinking about the current regulatory environment? Kind of what is top of mind in terms of what we should be thinking about to proactively as an industry kind of move in this direction, and maybe not be caught flat-footed as some of this stuff comes forward?
It's a good topic, Christy, and I think CVS has an advantage, and certainly in my background, my time in the MinuteClinic division of CVS, price transparency has always been out there in the forefront. MinuteClinic has published their prices for years, and let the consumer make decisions based on that. So we're working obviously to comply with all the other transparency rules that come in there, but it comes into and supports the consumer really making more well-informed decisions. Also, it helps providers as we coax them into those discussions with their patients about prices. This is something that we've around these particular compliance rules, whether they're CMS or ONC, we have dedicated significant resources to complying with these. And I can honestly say that our team looks to exceed and go beyond and improve upon. We don't want to just meet the letter of the law. We want to be able to provide a better consumer experience, which is where it just falls in line with what CVS is about, and caring for our patients and our members. So we're spending, as I said, because it's significant resources here and support the compliance effort.
Yeah, awesome. Sarah, what about you? What are you guys thinking about? And I think, Jim, to your point, obviously this regulation is in line with doing what's best for patients and really trying to further outcomes. And I think, Sarah, you've already spoke to it a bit, but, specific to this, kind of how are you guys thinking about it?
Another, I think I agree with everything that Jim said, and we're very much aligned with that as well. One thing that I think isn't necessarily reflected here is then like, what are we actually trying to do with this in terms of what actions are we trying to promote with our patients, and how are we doing that through the way that we're surfacing this? And we're doing it in a number of different ways. One is the example that I referenced around RX review. We're also doing, we are building an engagement platform that, to some of the discussion earlier, is another channel by which we are, before and after kind of specific clinical encounters, reaching out to patients, establishing a relationship with them. And we're also using that to promote specific sort of transactions and actions with our patients. And a lot of the sort of rules by which we are informing how things are personalized are going to show up there to the end user. And so that's where, that's where these things actually go. Ultimately, it's integrated with, we're on Epic, so it's integrated with Epic and MyChart. So we have that aspect of it in there. We're looking at actually tying together, for instance, payer and provider data and benefit data from our employers to really say, like, from a holistic experience perspective, there is no wrong door. So exactly what the out-of-pocket expenses to you that surfaced up to you in that relevant channel from an engagement perspective, for you as an individual, not just sort of high level, in general, this is the range that you might expect. So that's those are a couple of the things that we're thinking about. And I think, these are just enablers of that. These regulatory kind of things that you've listed here are enablers of those experiences ultimately. The other piece I will say is that increasingly we're starting to move toward just a more kind of, and we've been talking about this as an industry for so long, but a more consumer oriented mindset in general. So for certain businesses even, and certain services that we have, like having flat pricing, or like it will never exceed this amount for you. So provide, taking steps, that's one step without requiring a lot of, frankly, fancy data sharing, but that we can just take to start to enable that more consumer shopping experience. Those are a couple things. And I just think it's important to note that these are on their own only going to have so much utilization or utility unless they're actually surfaced in a meaningful, personalized way to the user.
Yep. Sam, that's a perfect transition.
I would just concur with Sarah and Jim. I mean, this is obviously the regs are important. It feels like all regs right now are interoperability related, and price transparency being one of many, just making sure information from the outside is available at the point of care. But it doesn't go nearly, I don't think regulatory needs to be the thing that pushes it over the edge. But it doesn't go nearly far enough in terms of what I think providers intend and want to go accomplish with their patient experiences. And frankly, pricing is so complicated for a patient. I mean, think about it. I've done this with, I worked in revenue cycle. I actually did price transparency early in my career. And when we got new associates, we'd say, all right, here's your copay, here's your co-insurance, here's the coupon from XYZ, here's this, what are you going to pay? And like 9 out of 10 could not do the math within, 20 seconds to figure out how much, or they do it wrong, they get the wrong answer, because it is so complicated. And so this is where I think Sarah's ideas around flat pricing and really, some of the work I've seen from some of our clients around identifying the shoppable procedures and shoppable, medications that really need to be face up, have simplistic pricing that goes beyond just kind of the formula of copay, high deductible plan, HSA, all those things that come into play when deciding, if you're going to adhere, how you're going to adhere. So a bit of a tangent, but I think the idea is regulations we take seriously, our clients take seriously, we invest tremendously in. But in this space, I think there's opportunity to just go way beyond what's being regulated to create positive consumer experiences, which the likes of CVS and Providence are leading the way in.
Awesome. Well, from there, we're going to jump into technology, which I think is kind of a funny thing because all we've done is talk about technology, but we're going to do it in a more kind of maybe specific way. So I'll start just by, hammering home a point that Sam made, but I think everybody's made, which is, one thing that's hard about this is building a network that can provide comprehensive information so that, you have the set of payers and PBMs at the table, you're able to reach a meaningful set of providers on the other side of that network. And so what's on the screen is our ARGS review network, but I think representative of kind of one of the issues that's been called out, or hurdles maybe in terms of building a meaningful network on both sides, so that you can compel the PBMs and payers to participate, but also have something really meaningful for the doctors on the other side. The second thing that we think about in terms of our role as a connector is consistency and quality of information, which is the second thing, Sam, that you hit and that we've kind of hit thematically throughout. And so, in our position, that's absolutely kind of what we think of as a key part of our role in terms of taking all this sourced information and having an ability to streamline it in a way that delivers to the provider consistent information, even if coming from disparate sources, and information that they can trust in terms of the real-time nature and the patient-specific nature of the information coming forward. So, Sam, I'm gonna pick on you because I used a lot of what you teed up for me. But from your perspective, what are other challenges here? Is there something we're missing in terms of real-time meaningful data connectivity and kind of the hurdles there?
Yeah, I mean, we have some of these capabilities. Our ARGS Review has been a great partner here, rolled out in various systems. And I think a consistent theme of whether or not there's uptake and adoption is really around, beyond technology. The momentum is driven by shifting incentives for physician at the physician level due to like value-based care arrangements. So where those arrangements exist, and not just the arrangements at the system level, but where systems are starting to change models of care and kind of their expense management practices, inclusive of physician compensation and incentives that drive the holistic quality of care plus the cost of care as a balancing act. When you do get the risk placed upon you, you start to see, hey, this is an important step in managing medical expense, is both adherence and which is driven a lot of times by the economics, and understanding the alternative therapeutics and other things that really become part of the care process. So it's a real shift in mentality that incentives drive to create a more proactive demand for things like real-time benefits and even like prior authorization workflows. And I think there are some systems that are very advanced, that have come like really made a shift towards value-based care. But I think that is a consistently moving train that maybe is coming a little slower than some people predicted years ago, but is continuing the appetite for value-based care. And I think even though the capabilities exist, unless the incentives are aligned and the overall health economy comes together to support things like patient experience and kind of affordable care, the tech alone will not get us there.
Yeah, that's fair. How do we get providers engaged? How do we have people paying attention? So yeah, that's a great point. Hey, Jim, how are you thinking about, I'm going to hit you with an information question again, but you mentioned cost and coverage kind of as the primary type of information you're focused on getting to the point of care. But, is there anything else you're thinking about in terms of information that needs to be served up to patients or providers in a different way?
I think, I won't rehash the cost and coverage piece, but there's a lot of clinical intelligence or I don't want to use generic terms like gaps in care and things like that, but there is a lot of information that exists within a provider realm and within a payer realm. And then we have the unique opportunity to bring those together and really develop and support a clinical story of the patient. Where are they going? Where are they compared to other patients like them? What sort of information can we get to those providers? Again, along with all the others, it has to be integrated in the workflow. It has to be simple. Some of it has to be actionable, where it's, a click or two to take that recommended action that, based on our data analysis, improves the outcomes for the patient. So a lot of the clinical history or clinical intelligence analytics that the teams are working on here at CVS Health can be presented in such a way, and we're very focused on that as well. Really, not just with our own providers, but collaborating with providers in the community to make sure that we're offering up the best of what we know, whether it's from our healthcare benefits, from our pharmacy benefits, or other areas of the company. So it dives deep into the clinical aspect of it.
Yeah, absolutely. That makes great sense and is a good segue. So we just wanted to throw up on a slide kind of how real-time data exchange can impact and benefit every constituent, and kind of back to the point Sam was making around incentivizing providers, Jim, to your point around kind of the suite of information that needs to come forward. But we've been working really closely with Cerner on tools around, both cost and coverage transparency of drugs, but also medical procedures, specialist referrals, lab orders, that can both drive visibility into prior authorization, visibility into the cost of care, as well as the sites in which to go get that care. And then we're also serving up, to Jim's point, information around gaps in care, around the claim-driven record of care for a patient, truly to this point of, how can we get the information? How can we take what's in the pipes, right? We've got those pipes, and how can we take it and serve it up? And I think, to the point being made, continued opportunity to serve that up in a really meaningful way to every constituent involved. But generally, I think excited about the way incentives are aligned here, and starting to become more aligned for everybody to participate. I'll just tell one quick story, and then Sarah, kick it over to you just to kind of give your perspective on value to these stakeholders. But we're getting feedback from a doctor, specifically a pediatrician, and he was telling us a story about using our ARGS review real-time benefits information. And he had a patient who had been diagnosed, needed an inhaler on an ongoing basis, had gotten a prescription from a specialist, and then an inhaler was $200 a month. And the mother was really concerned about an ongoing prescription that cost $200 a month. And when he used the tool, he saw that there was a $0 option. There was an inhaler that could work for this patient for $0. And I think it just, as you can imagine, the mother was thrilled, crying, hugged the pediatrician, like couldn't be more relieved. But I think it really highlights where, the plans and the PBMs are working on formularies that can have a real impact for patients. And to the extent that we can bring this information together, there's an opportunity to drive better outcomes without some of these bigger, more, more comprehensive reform that others are talking about. And so just wanted to highlight that as, even as this might feel like somewhat small step of connecting information, really meaningful in terms of what it can do. So with that, Sarah, talk to me about how you think about value to all these parties, and how we continue, to Sam's point, to tell the story about why providers, why patients should be paying attention, and how we can help them get better outcomes.
So, there is value. As you were talking, I was kind of trying to disaggregate it into like the different components of value, not in terms of where the economic value necessarily is, but just more generally this concept of value. So I think, there's value at the point of care that you just described. This is like when you are face to face, we have a notion of like a sacred encounter. That's what we call it at Providence, but in like maximizing the care that can be delivered in that moment, and augmenting the sort of traditional care with additional resources, financial benefit, et cetera, right? Like there's that source of value there. There's also using value, like using this sort of framework to create engagement and drive value after the point of care. So for instance, we've done additional work around using every engagement between a clinician and patient to then generate a follow-on action that has digital sort of connectivity that the provider can track within the context of their workflow. So for one example is the ability to prescribe digital products and services in the point of care, but for utilization after the point of care. And then that can generate value in terms of, ensuring that you were talking about how do we actually get providers engaged? How do we actually get them to drive adoption in some cases? That is one way by which you can do that. Digitally prescribing products and services that then patients can use after the fact. The provider can track it, again, in sort of a meaningful way, and ensure that there's continuity and that every interaction actually generates follow-on interactions. And then there's value that can be generated around, any sort of clinical encounter that can be targeted toward driving next best clinical action, improving, driving you to kind of do specific things, whether clinical or non-clinical, as a consumer that can keep you healthy. And so I think we can think about it at different parts of the journey, and there's value that can be generated in any of those. And so that's one way of thinking about it. But, for us as a health system, like the core thing that we're trying to accomplish is at the highest level, achieving the quadruple aim without burdening our providers. And you can do it at any point in the journey through this kind of mechanism.
Yeah, that's a great way to say it. All right. With that, let's talk about where we're going. So goal of the rest of the time here is really to say, what's possible, what requires more focus, where are we ahead, where are we behind? And I'd like to just have each of you kind of take a second and say, what is the near-term future? And in a somewhat aspirational way, but what feels kind of within our grasp and that we should really be going after in short order in terms of either, places where the pipes need to be improved, places where kind of the experience needs to be improved, but kind of what do you see that end state looking like, and how do we get there? So Sam, I'll tap you to start this one off. What are you thinking about?
Yeah, sure. I know better than to get way over my skis on this stuff. It's hard. It's a long journey. So I'll just express excitement about the work we've done with RX Review to incorporate real-time benefits and price transparency in the workflow so far. There's definitely an adoption curve here, and kind of more enhanced usability that I would say, I know that's a micro goal, but that's a big challenging thing we need to stay focused on and continue to evolve for the clinicians, for the patients and their own digital tools, all the things that Sarah's all over, and I'm really excited to hear about. And then we all see promise in automating prior authorization as part of the clinical workflow. So leveraging electronic exchange during the natural course of clinical work to get to those prior auths much quicker. We've seen more advances, I would say, on the prescribing side than we have necessarily on the medical side. But holistically, our involvement with the Fire Da Vinci project and some other kind of industry standards bodies to try to advance, hey, what are those points of data exchange? How do we use hooks in the EMR to drive process in a smart and like Sarah said, automated, contextually aware way, to where it simplifies these very arduous processes. And I'd say we are just scratching the surface there and have a long way to go. But those are kind of those items on the horizon that I'm really excited to be kind of where we are right now, about to go tackle in the industry.
Yeah, fantastic. Jim, what about you? Where do you see this going?
I think I would agree with Sam. Our activity in Fire and Da Vinci are really good, but I think at the heart of it is the discrete actionable data. We have to get more, we have to push the standards bodies and push innovators really to get more actionable data, because that will enable additional tools for us. That enables us to automate more and to move more off the plate of the providers, so they're focusing on medical decision making with the right data in front of them. There's been a lot of work, and other people in my circles will tell you I'm on a crusade to eliminate fax machines from the face of the earth. And I fully admit that, but there's a lot of work on what we can transmit, but it needs to go at a deeper level. We need to get more discrete data, less narrative fields in there. I think a lot of organizations are looking for that and want to push that forward. So I think that's good. And that does, as Sam said, it goes into the patient's digital experience. It goes into the provider's experience as well. So I think that's a key driver. And then one last thought about this, somewhat outside this realm, but as we talk about all this data going back and forth between disparate systems, disparate organizations, one of the key things that I think we need to tackle is the patient identity algorithms. How do we ensure, from not only from an experience, but from a patient safety perspective, that we are talking about the same patient in all these same systems? I think we're good there, but I would push the industry to do better.
That's a great call out. All right, Sarah, how about you?
Like Sam, I'm not going to go too far out because that's just a recipe to be wrong. But I can say what we're thinking about as a very near term thing that we're actively working on is sort of the consumer angle to this, right? Driving engagement through personalization and navigation, and that that's this ensuring that what you're seeing has utility to you, it's relevant to you as an individual, and that's being driven by your clinical data, your non-clinical data, like your search history on our digital properties, for instance. So we have a more holistic sense of you as an individual, not just as sort of the clinical snapshot of you. So, bringing in demographic data, bringing in your payer data, ensuring that all of these can then drive an experience that is relevant, and then help you make your way through it. So that personalized experience that is then, I would add one additional layer, is orchestrated, not static. When we see anything that's kind of surfaced up to consumers nowadays, it's generally everyone sees the same view, but in e-commerce, everybody's view is different based on their purchase history, their search history, everything that Amazon knows about you, Christy, is different than what they know about me, and our homepages are different. And so that opportunity to personalize that at that level, I think, is really important. And why I think it's relevant in this context is that actually takes a lot of the burden off of the provider, because they're not responsible for doing everything themselves. They can actually have an informed patient riding alongside them.
Awesome. All right. Let's shift to Q&A here in the last 10 minutes. There are a couple of questions that have come in. So, Sam, you talked a little bit about social determinants of health. One question here: how are panelists considering Lucy if she's Black or Indigenous, living in a low-income zip code? So, if it's okay, I'm going to start with you on that one. But Jim or Sarah, if you have something to add, chime in. Go for it.
Yeah, I mean, my previous boss at Intermountain really declared that there's a public health emergency with health equity, and I wholeheartedly stand by that. We are not doing enough in the realm of narrowing it down to price transparency. I hope that my hope is that these things play in a very equitable way. But I think the problem goes way beyond this particular workflow into just the heart of healthcare delivery, and I'm encouraged by our clients and their healthcare providers on the line, and kind of where their focus is, and we're 100% behind it. So I'll hand it off.
Yeah, I would just add that CVS Health certainly committed to incorporating the social determinants of health and other demographic information into that. We just recently, within the past month or so, maybe month and a half, created a new position and brought on a chief health equity officer. And we're really excited about what Dr. Khaldun will bring to our organization and help us be better at incorporating those aspects into our care.
Yeah, I agree with both Sam and Jim. Nobody is doing enough, and it's a pretty big industry-wide disgrace, I would say. But Providence is starting to make some pretty significant steps in the right direction. We have a very significant financial commitment behind health equity. And then from a technology and outreach perspective, we've started to segment the patients that we at least have some information about. Now that's a big, there's sort of a big bias there already, right? Because we have some information about them in terms of their demographic data, where they live, race, ethnicity, et cetera. But we are able to segment, and we've started doing some targeted outreach. So for instance, in early COVID days, we identified folks that were at risk of not having as much information about COVID, about kind of the latest standards and information about how to keep yourself safe, where to go get tested, et cetera, and did personalized, or rather segmented, texting campaigns to reach out to them, to provide them with that information. And there was a bit of like a flow that they could go through to get information that they thought was most relevant. So that's like one starting point, is just ensuring that folks get information, that they get it in the modality that's relevant to them, whether it's text or phone or app or whatever. But we've got a very, very long way to go.
Awesome. All right. With members switching employment frequently and possibly PBMs, how do we handle ensuring their history is accessible and relevant? Jim, I might start with you on that one. Just a point of view on maybe lifetime of a member, how long or short that may be, as well as keeping all that information together.
Fortunately, the regs, and I'm not going to remember which particular one, whether it was CMS or ONC, did mandate that payers at least would have access to the previous clinical history. And so that's one way in which we are looking at, well, let me restate this. A lot of us, including CVS Health, when interoperability regs started being published, were very focused on complying with sending information, making information available to the patients and to other parties as required. But within those regulations, also our ability to transfer that information and make it easier for the patient. So we can get, anyone can correct me if I'm wrong, I believe it's 5 years of history when a person transfers from one payer to another. So that helps, as I mentioned early on, that clinical intelligence or clinical story of a patient, that helps build that really from day one of being with a new provider, or I'm sorry, a new payer. That will help improve our awareness of their history and develop more meaningful information, insights, interactions for the providers through these fantastic interoperability channels that we're building.
That's great. And then Sam, there's a complimentary question I'm going to throw to you, which is, same thing. What information, in addition to diagnosis, treatments, is important as patients change doctors, as they go to a different provider? And how are you guys thinking about sharing that information?
Yeah, absolutely. I mean, that's the world we live in, right? Every patient is going to see multiple providers and different systems, so they won't even stay within the same IDN, especially when there's things like high deductible plans, PPOs, things that really give patient choice in terms of which providers they're going to see, and the fluid transmission of information that follows the patient to whatever venue with whatever EHR that provider or kind of community practice is going to be using is extremely important. And so that's where I think interoperability ultimately is a team sport, right? We all have to come with good intention into these, generally nonprofit standards and boards and consortia where we can pull back our competitive lens and really talk about how to make this best for patients. And that's been a commitment, a wholehearted commitment from Cerner for 40 years, and something that we continue to really advocate is in the space of getting data to follow a patient wherever they go. That is a fundamental and something that we need to support. Every one of us has a family member who has had cancer or had serious medical conditions that have had to transfer between facilities and bring shop bags full of paper with them wherever they go. And so that's the problem to solve. And it's something that I hope that we're doing our best with, and there's a long way to go.
Yeah. And then, Sarah, there's a question around, tools for Lucy, and when there's tension between fee-for-service type procedures or, incentives back to the providers versus, maybe the right thing for Lucy. And how do you guys think about, what are you doing to kind of make sure that doesn't happen?
I would say top line is we actually try to create models and engage with partners who don't force us to make the decisions around the transition economics ourselves. It's very difficult. And what that actually means, it's essentially we try to work with solutions that can support us in either a fee-for-service or a value-based environment. Like the examples that I provided around for instance, providing digital apps and services like prescribed in the workflow, that works under any scenario, right? It simply augments the provider's ability to have information about their patient afterward, ensure that they're getting the right program, and that they are engaging with it, and that it's supporting their care plan. It's somewhat independent of the individual payer or program that they're in. Now, provider compensation is a whole other story, so I won't even go there. But I think for us, I think we are increasingly trying to avoid having to make decisions based on whether it's a fee-for-service environment or not. I don't know if that's a satisfactory answer. We could get into a lot more detail there.
Yeah, I think it's what time's gonna allow, so that's fine, Sarah. Thank you. There's we've only got a couple minutes left here. There's a question about how close are we to automating prior authorizations, and I'm not sure any one of us can answer that question. That might go into the going a step too far, getting over our skis in terms of future state. I'll just say there's a heck of a lot of focus and absolutely a priority, I think, for everybody in terms of increasing the speed in which patients can get care, but also reducing the administrative burden back to our providers and their teams. So
yeah, I think the one thing we could say is actually prior auth, it's not tackling it all at once, right? There's some very specific use cases that we can start to go after. Specialty pharmacy is one that we're starting to look at more, right? That's a very painful process, and but it's also much more sort of actionable than just saying, oh, we're going to tackle all of prior auth for any sort of service. So I think we're not close by any means, but kind of picking some specific use cases, we've been starting to tackle them.
Yeah, and I think to Jim's point about killing the fax machine, I also think, at least on the drug side, really significant progress around electronic data exchange. Now, that doesn't mean we're automating question population or anything like that, but really significant progress in terms of getting rid of fax in that channel. All right.
Christy, I would point out that
Yeah.
the CAGR for the eFax in healthcare in terms of expended cash from health systems is higher than the growth of interoperability as a product set. So I don't know that we've slowed down the fax machine just yet.
Yeah. On that highly encouraging note, I'm
Thanks,
gonna
Sam.
thank all you guys for joining me. I really appreciate the discussion. It's been fun to talk today. And I'm going to kick it back over to the health team and to our mentalist that's joining us. Thank you, guys.
How is everyone doing today? Can you hear me?
Great.
Excellent.
Hi, Dan.
Sam, Jim, Sarah,
Thank
thank
you
you
to
for
Chrissy and
having
to
me.
all of our panelists. Please visit our website to catch up on all Health Go Live webinars. And join us at the inaugural Vive event, the industry's new health information technology event, coming to Miami Beach, March 6th through 9th, 2022. And now, please welcome magician Dan Chan.
Thank you once again for that great introduction. Well, recently we have had mask mandates back in California, and as a magician, my wife has been asking me, Dan, if you're a magician and mentalist, how can you read minds and forget your mask? Which is a very logical question, isn't that right, Sarah? Now, as a magician, the only thing I have to do is I have to just reach in the air and I can pluck one of those out. Thank you. Well, since I'm in my own home studio, I don't have to wear my mask. Let's start with one of these. This here is a Rubik's Cube. I'm going to try to give it a couple of spins. I actually have only about 15 minutes, so I'm going to try this. And that is a quick trick. Thanks, Sarah, for your reactions. I'm loving this. Awesome, awesome. Sam, how are you?
Doing well, Dan. How are you?
Good. By any chance, you're not colorblind, are you?
Nope.
Okay, that's good because we're gonna need to have you help out with this next effect, and you will need to just say the colors first, okay?
Okay. Purple, green, red, blue, pink, orange, yellow, brown.
Perfect. Okay, this time we're gonna ask that you not just say the we're not gonna ask you to say the color. I'm gonna have you say the font color that's written. Not what's written, but just the color itself. Make sense?
Okay, I'm going to confirm I have good color on my screen. Is this one brown?
Yes, it is brown.
Okay, brown, purple, yellow, red, black, green, orange, blue.
Okay. Companies use a lot of colors if they're strategic to influence you. For example, you can see all these colors and the associations with both brands and what they want to convey. In a moment, I'm going to try to convey a message to you. I'm going to send you a number, and hopefully you'll be able to pick up on this number. because you're going to be the mentalist, Sam.
Okay.
What number between 1 and 8 did I just send you?
8.
8. Now, you could have said any number, correct?
Yeah.
And we never met before today's show. But you
Nope.
somehow picked up on the number 8, yes?
Correct.
This is the first one. 1, 2, 3, 4, 5, 6, 7, 8. The word written is your conscious. The word font or the color is the subconscious message that I brought to you. What color is that there?
That's blue.
I subconsciously got you to think of blue. And that is exactly proof positive. Thank you. Thank you, thank you. We have time for one more. Sarah, welcome to my virtual stage. How are you again?
Doing well, thank you.
I would love to send you a gift, but in order to send you a gift, I only send it during birthdays. So Sarah, I'm gonna need your personal information, and it's okay because of privacy concerns, you can lie about your birthday, okay? You can just make it your friend's birthday, and I'll just send you the gift at your friend's birthday, okay? So go ahead and give me the birth date of yourself or another family member, a date that you would like the gift to arrive.
March 29th.
Very cool. So make sure you all follow along with me if you're watching this. 3 plus 29 plus the year you were born or that other person was born.
1979.
1979, and then I hit equal. Okay, I'm gonna need the last 4 digits of your social security number, your mother's maiden name, your ATM passcode, and the name of your first pet. Now, due to privacy concerns and strict health standards, we're not allowed to do that today. Isn't that right, Sarah?
I would hope not.
Great. We will add 4 random digits, and everyone, again, follow along with me. We're going to add 4 random digits. Oops. Oh, we'll go 2 more. 2703. For those of you who are following along, feel free to message me what you got in the chat bar. Make sure that I am not cheating. Okay. Oh, you can message it to everyone. That's great. But we do have verification that that is 4714. Sarah, does that mean anything to you?
I don't think so.
It's not your ATM passcode or your thing to unlock your phone?
No, it's not.
You're sure?
I'm
Just
positive.
think about that. I'm sure it relates something to, maybe it's Sam. Sam, does it have anything to do with you, my friend?
I don't think so. Nothing ringing a bell.
Jim, last one.
No.
Anyone? You know what? Sometimes Santa leaves surprises. Did you know that, Jim? We all know that. But
Well, no.
behind me in the stocking is something that Santa left. Four, 714 is a number you guys came up to. Not only that, HLTH. Thank you very much. My name again is Dan Chan, the Millionaire's Mentalist. You guys are a great crowd. Thank you again.
Thank you.
Bringing the razzle, abracadazzle, fun and casual. Welcome to the magic show. Bringing the razzle, abracadazzle, fun and casual. Welcome to the magic show. Dan Chan, the magic man, corporate magician in San Fran. Dan Chan, the magic man, corporate magician in San Fran. Dan Chan, the magic man, corporate magician in San Fran. Dan Chan, the magic man, corporate magician in San Fran. Dan Chan, master magician, innovation mixed out with tradition. Pick any card, you know that in an instant. Remove hat and the rabbits go missing. Shows up like camping, it's very intense. Blow your mind every virtual event. Billionaires ball in his audience.